So our next speaker, R.J. Gillespie, is a general pediatrician with the Children's Clinic in Portland and is the medical director of the Oregon Pediatric Improvement Partnership, housed within Oregon Health and Sciences University. Since 2007, Dr. Gillespie has worked on a variety of statewide quality improvement initiatives focused on training providers in developmental screening, postpartum depression screening, medical home implementation, behavioral health integration, and adolescent health. He's involved as a member and advisor to a whole long list of policy committees at his state, which if you want the list, take me aside and I'll give it to you. For the sake of time, I'll skip it. It's incredibly important and long. Most importantly, he's brought his experience in medical home implementation to the American Academy of Pediatrics Medical Home for Children Exposed to Violence Project Advisory Committee. And he's here today to speak on identifying toxic stress in your pediatric practice. Please welcome R.J. Gillespie.
Good afternoon. I'm excited to be here and certainly excited to see how many people are interested in this subject. I'll just get right going. As far as disclosures, I have no financial disclosures. I am open to the idea, so if anybody wants to pitch me something during the break, I'm sitting right up here. But most of the time, I really am a rank-and-file pediatrician. So what I'm going to present to you today is a framework, a fairly simple framework for how primary care pediatricians can incorporate an assessment of trauma into primary care. And I'm going to provide the beginnings of an example from my own clinical practice in terms of what we're doing, but most of the detail of my practice's work is coming Monday morning in a session that I'm doing Monday morning. So I always start with the framework of the American Academy of Pediatrics medical home definition, in that care for children should be accessible, continuous, family-centered, comprehensive, coordinated, compassionate, and culturally effective. Now, when you're thinking about children who've been exposed to violence or children who've been exposed to toxic stress, there are two of these elements that I think are particularly important, and the first is family-centeredness. And I think that as pediatricians, we've all had the no-duh experience that kids don't grow and develop in a vacuum, and that really the context of the family is extraordinarily important for understanding how children grow and develop. And so the family-centeredness definition, recognizing that families play a vital role in ensuring health and well-being of the patient, and acknowledging that social, emotional, and developmental support are integral components of healthcare. And I think the other piece is comprehensive, that it's not just about ear infections and sore throats, that we really need to look at medical, behavioral, and social issues and treating the whole individual and all of his or her needs. Now, as you probably know, since medical home has been around for a long time, that the concept of medical home was originally developed for children and youth with special health needs, and it was meant to improve the care that was given to a particularly vulnerable population. And so I think the Maternal Child Health Bureau definition of children and youth with special health needs is relevant to this conversation. Children with special health care needs are those who have or are at risk for a chronic physical, developmental, behavioral, or emotional condition, and who also require health and related services of a type or amount beyond that required by children generally. If you haven't gotten the message yet, toxic stress has huge effects on a person's physical, emotional, developmental, and social health. And so these children really do fit very neatly into the definition of children and youth with special health needs, and therefore the medical home model really needs to be extended to this group of people. As I mentioned, they are children who've been exposed to violence are at risk for poor health outcomes. They need additional services as compared to other children, and they deserve some degree of tracking and follow-up. As one of my colleagues in the Defending Childhood Initiative back home says, children who have been exposed to violence need developmental promotion times 10. In terms of a medical home framework, I think when you're thinking about medical home principles, there are really 5 steps to applying a medical home principle to children who've been exposed to violence. The first is to identify the population through screening or surveillance and track them. And the point that I'd like to make here is that not every child who's experienced toxic stress is going to be obvious to us by their symptoms. And so without some sort of universal approach to screening or surveillance, you may miss some children who are in fact at risk. There are going to be cases where the symptoms are latent from the exposure, so you're going to need to think about a more universal approach rather than only focusing on the children who you think might have symptoms. So this is meant to expand on what Dr. Forkey was presenting with children who are presenting with specific somatic symptoms. The second is assessing the family and patient's strengths and assets and the need for specific services. And this really is understanding the family's resilience skills and understanding how the families cope with stress and how they teach those particular skills to their children. The third is making referrals when appropriate. The fourth is providing self-management tools, and I focus this primarily on developmental promotion, and again, that children who've been exposed to violence need more developmental promotion probably than children who have not. And I really think that the basis of developmental promotion in terms of all of the things that parents can do to stimulate their child's development really track back to attachment. So a parent who is working on their child's development proactively and intentionally is attaching with that child. They're being present for that child, and that's hugely important in these settings. And then the final part is to follow up on referrals or close communication loops. For me personally, I think understanding the science of toxic stress and the lifelong effects of toxic stress, what we all want to think about is how do we create healthy adults? And so to understand which of the adults experience trauma is to understand how to help prevent their long-term health effects. But backing up to where we are in the space that we live in, which of the children that I take care of have experienced toxic stress, and how do I prevent this from happening, or how do I prevent the long-term effects? And really when it comes to toxic stress, we have two choices. One would be to remove or prevent this stressor, and the other is to help figure out ways to enforce children's resilience so that they can deal with the stress in a more productive or positive way. So from my view, when you're thinking about a screening or surveillance program within your office, and this is something that we thought through when we were implementing developmental screening, when we were implementing maternal depression screening and so forth, it really comes down to 4 questions. The first, why am I looking? The second, what am I looking for? The third, how do I find it? And fourth, what do I do once I found it? And in all honesty, whenever I'm starting a screening program, I start with the last question, because I think if you don't know what you're going to do once you've found the thing that you're looking for, then we have a problem. And certainly there's an ethical question behind why screen if you don't know what you're going to do with the information. It's probably better if you don't have a clear response to think that through first before you implement any sort of screening. And really, though, what do I do once I found it probably has 2 different ways of reading the question and 2 different tones. One of them is, oh my God, what am I going to do if I find it? So there's a little bit of a personal response in terms of how am I going to respond, but then also what am I going to do clinically? And so when I first started talking about screening for toxic stress, there were a lot of providers and a lot of practices that I talked to who were just terrified of the idea of getting into toxic stress and thinking that they're going to kick a hornet's nest and the visit's going to take 3 days to get through and basically sink you all together. And so I start with that conversation first. And I think that the perspective that I take, first of all, listening is therapeutic. And I heard somebody say the other night that when somebody is in a crisis, the last thing that person wants from their primary care provider is to say, just a minute, let me get you a referral number. Right? You have to be present. You have to stay in the situation and just understand that your role as a pediatrician may just be listening, okay? The second, and this is a quote that actually comes from one of my great mentors who's sitting in the audience right now, which I think is extremely important. When something becomes speakable, it becomes tolerable. That means when a person is able to talk about their stress, talk about their experiences, they can start drawing connections between the thinking brain and the feeling brain, and that's one of the first steps towards healing and integrating your experiences. So again, listening is therapeutic. So the thing that a primary care pediatrician really needs to do is be available to listen. The second comes from Principles of Motivational Interviewing 101. And as primary care providers, as physicians in general, we're used to this idea of the righting reflex. That is, that whenever we're faced with a problem, we need to fix it, and we need to fix it now. And so we're trained to face problems and fix them all day long. Motivational interviewing would suggest that oftentimes the solutions to a person's problems lie within the patients themselves. So they're going to have ideas about what they need, ideas about what's going to work for them. The third, put your own oxygen mask on first. And I think this is an important message, because one of my concerns in spreading this work is that as providers, we probably have experienced some trauma ourselves, right? And so the first step in being able to address trauma is keeping our own stories in line and understanding how our stories affect our assumptions that we make about people. So throughout this, in my practice, the key message that I'm trying to get to patients, you're not alone, it's not your fault, and I'm going to be here to help you. I'm going to sit with you through this and figure out what to do. So again, steps in trauma-informed care, and I know there are a lot of smarter people than me who talk about trauma-informed care, so I divide this into 4 very simple steps. The first, taking care of myself while addressing the trauma of others. I will say that the Simply Being meditation app on iPad costs $2.99, so that's one of the things that I do. I meditate every day. Interpersonal, can I listen effectively to the trauma history of my patients and families? And that again is about being present. That again is about checking my own assumptions at the door about what's going on with the family and really being present in the moment. Third, organizational, is my clinic a safe place to reveal trauma and address it? And then finally, are there community resources that I can use to help these patients and families? So that's really the environmental approach. There's another level in the environmental around policy supports, but I do policy work, but most of the time I'm a rank and file pediatrician, like I said. For me personally, in terms of answering the first question, why I'm looking, about 5 years ago, I was involved in a project called the ABCD3 project, where we were looking at once a child was screened for developmental disabilities, if they failed to screen, what happened afterwards. And one of the sort of alarming pieces of information is that from our study, and this was seen in other states who did the same project, is that of all the people that we refer to early intervention because they failed an ages and stages questionnaire, half of them never make it into services. Right? That's sort of an alarming number if you think about the fact that we've identified a risk and nothing is being done about it. Our study was a chart review of 280,000 kids across the state of Oregon through 8 of our Medicaid managed care organizations. And so I realized that I was not swimming in the right pool, right? That my medical model of understanding developmental risk and follow-up was not big enough, and that I really needed to start understanding why a family wouldn't go into a service that I recommend. And my gut, and one of the things that I'm working on right now in my practice, is that the families who've experienced toxic stress or who are in disruption are the ones who are not going, which means that the kids who are at highest risk are the ones who are not getting services. And that to me is a big problem. So this is why part of why I started getting into this particular work. And so the why am I looking question that everybody should answer, and certainly you understand at this point what the health risks are, and so the why this is important probably doesn't need to be answered. But why am I looking? And I think it's important to consider, is there a particular need in your community or patient population that needs to be addressed? Is there a particular interest amongst your providers to address a particular practice gap? For example, is there a clinical problem that I'm trying to get a handle on? And that for me is the developmental screening follow-up. Or is there an outcome that I'm trying to improve? One of the things that I push in policy circles all the time is the idea of a shared measure around kindergarten readiness, which to me is one of the outcomes that we all should be thinking about and really should all be focusing our attention on, because it is an outcome for everything that we do in the first 5 years of a kid's life. What am I looking for? And I think that the different approaches for assessing trauma within a practice depends a little bit on the practice readiness and the goals of your screening or surveillance program. So some people would start with looking for a specific trauma or specific toxic stress. So for example, do you want to start screening all of your school-age kids for bullying? That would be one approach, right? Another approach would be to look at ACEs in general. So depending on your readiness and how bought in your practice is, you might take different approaches to that. Who am I screening? And again, I would argue that universal screening is important so that you don't miss any cases of people who aren't obvious to you. Or do you take the approach of targeting specific problems like somatic complaints, mental health concerns, school failure? And then the other question that I add on to that, and you've heard a little bit about this earlier, is the idea of screening families or parents or screening the patients themselves. Just a reminder that there are multiple different types of violence exposure, and I think one of the things that happens when we focus a lot on ACEs is that, the ACEs, there are 10 toxic stresses. There are far more than that, so I always want to remind people that there are different toxic stressors, as you've heard, that may not be captured by the original 10 ACE questions. And there are different levels of violence. So there's endemic violence, which is the stuff that's going on all the time, and then there's episodic violence, which I don't spend a lot of time screening for because to me it's usually fairly obvious when there's been a school shooting. Oregon had their third a few weeks ago, so we know that certain communities and certain parts of the state are going to be focusing on that intentionally. So that's not the type of screening that we're talking about. How do I find it? And this gets down to what sort of screening or surveillance techniques work best in your practice style and your best context. So is it a paper-based screening tool, or is it a surveillance question that you ask all of your patients? And there are some types of screening that are more amenable to paper-based tools. For example, there's really good evidence that screening for intimate partner violence comes better from a paper screen than from a direct interview, which can be re-traumatizing or can be a little bit difficult for mothers to answer the questions about. And then how also, when you're doing your assessment, will you maintain respect, privacy, and trust for your patients? So how do I find it in terms of deciding on an office workflow? And this gets down to the nuts and bolts. What visits am I going to start asking screening questions, and how am I going to do it? Is this a pre-visit questionnaire versus a direct interview? If it's a questionnaire, you have to think through who's going to distribute it, who's going to explain it to the patients, and who's going to get it to the provider so that it can be used during the visit. And at the same time, again, you want to ensure patient privacy as they answer the questions. If you're doing a direct interview and you have an electronic medical record, you're probably going to want to program in some decision supports into your electronic medical record to remind you that these are the questions that you intended to ask. And then how do you document the results? Setting the stage, and these are some examples of some scripts, and this comes from Futures Without Violence, so these are some ways to introduce the subject. I've begun to ask all women, parents, or caregivers in my practice about their family life as it affects their health and safety and that of their children. May I ask you a few questions? Another, violence is an issue that unfortunately affects everyone today, and thus I begun to ask all the families in my practice about exposure to violence. May I ask you a few questions? And what's important about this is that the message in the introductory script, again, gives the message that this is universal, that I'm not targeting you for the particular screening questions, but this is something that I ask everybody because it's important to everybody. Surveillance tips, if you go on to the Resilience Project website, there's some specific surveillance questions that we put together for different individual exposures, like some questions you can ask to get at bullying, questions you can ask to get at dating violence, and so forth. So rather than list through all those, I'm just going to refer you to the website. And then the universal surveillance question, which you heard in Dr. Forkey's talk, since the last time I saw your child, has anything really scary or upsetting happened to your child or anyone in your family? So this is a general approach if you're not looking for specific violence types that you can use in your practice as well. What do I do once I found it? First of all, again, keep calm and carry on. Again, keep your own story mastered, right? But in terms of next steps, first, assess the child and family safety. Second, again, look at the assets and resiliency in the families. What are the strengths that particular family has that you can capitalize on? One of the things I didn't mention on the surveillance question, somebody at the Violence, Abuse, and Toxic Stress conference in San Francisco in July said that in addition to asking that surveillance question, they like asking a strength question. So since the last time I saw your child, have you done anything fun as a family, which I really like, because that, again, kind of gets into some of the resilience building. There may be cases where you need to do follow-up tools for assessing mental health in patients, whether you do a pediatric symptom checklist or some sort of PTSD screening. That is, again, a next step. And then connecting with appropriate resources when you need to. As you've heard, there are a lot of influences on outcomes. So it's not just a question of asking about toxic stresses, but also trying to understand some of the protective factors or increasing resilience. And once you have a handle on a framework for resilience, I think the opportunities to talk about resilience start becoming natural within your practice. I like Ken Ginsberg's 7 C's, that a person has resilience if they have connection, confidence, competence, character, coping, control, and contribution. And really the most important factor in all of this is the connection piece. So having safe, stable, nurturing relationships that you can rely on for guiding a child through stressors. So other protective factors, living in a safe, cohesive neighborhood, parental warmth and monitoring, and a parent who doesn't have trauma symptoms. That doesn't mean that a parent couldn't have had trauma, but that they've, again, mastered their own story so that they're able to parent without having overt symptoms. And then what do you do once you found it? I think that community connections are sometimes important depending on what you found, but I am also, as somebody who is seeing a lot of patients every day, I don't have a ton of time for making community connections on my own. So remember that somebody in your community has made lists of resources somewhere. So these are some of the places that you can start for finding those lists of resources that you might need. So your local child abuse hotline would be one. They have all sorts of referrals that they can do. So they can be a resource for community agencies. And one of the things that I'm particularly excited about in Oregon, which has been a slow process, but it's coming along, is the idea of all of our Child Protective Service county agencies moving to differential response, which means that rather than taking a child who's experienced violence and putting them in foster care, meaning a one response fits all, that they're getting at root cause of the violence and trying to offer supports to families. So their goal right now in the differential response is to support parents who need extra help, so that, you know, if they made a bad mistake or a bad decision in their parenting, that's fixable, right? So that's something that we can work on. So consider local child abuse hotlines as a potential partner. Hospital and health plan social workers will have resources as well. There's family-to-family network that often knows the peer-to-peer type resources that you can tap into. Public health departments, Futures Without Violence and Defending Childhood is present in almost every state, I believe, and so they are another resource that you can use. Also mental health organizations, and if your state does a 211 info or help me grow type process, then that would be another resource that you can tap into. All this to say that, again, you don't have to reinvent the wheel with identifying your resources. There are people who have done this work for you, so connect with them. So, my practice at Children's Clinic. So, we have 28 providers and 2 practice sites. We're an independent, single specialty practice, and we've been working on a variety of different early childhood development and developmental promotion projects since 2008 is really when we started going on all of our different screening. So just to give a background, we do standardized universal screening for developmental delay, autism, maternal depression, adolescent substance abuse. When it came to assessing for children's exposure to violence, we have an adolescent questionnaire that we've used for years on all our kids 12 and over that had some questions about dating violence and some questions about some of the household functioning, but it wasn't a formalized or validated set of screening tools. And then many of the providers were asking about bullying in their history for school-age children, so we'd had some experience with looking into children exposed to violence, but not a ton. But in 2013, a couple years after I'd started working on the AAP's Project Advisory Committee, one of my partners, who I think is probably smarter than me, had done her sabbatical where she spent time with developmental pediatricians and psychiatrists and psychologists because of a really bad case that she had where she was working with a mother who she felt was high risk, was not doing great parenting, but was engaged and was really trying. And she had one of those situations where the child was biting her, and she didn't know what to do, so she asked her mother. Her mother said, "Bite him back," right? So the kid goes to school. Of course, the teacher sees it, and what happens? The kid's put in foster care, right? Because the teacher had to report it. So the mom comes back to Dr. Pedersen and says, "I'm never telling you anything that happens in my life again," right? So she wanted to understand, how do we get a handle around toxic stress? So she came to it with a really deep-seated passion from some bad experiences. I came to it from, I guess, a systems knowledge, how to figure out how to get medical home working. And so we sat down together and decided we need to do something about this, so what are we going to do? And we first started talking about whether we wanted to screen children for their adverse childhood experiences themselves, and if so, when were we going to do that? Or would it be better to look at parent experiences? And if we were going to do that, what do we screen them with, and when should we do that? And we really felt like screening parents for their adverse childhood experiences was going to get us closer to prevention of the transmission of toxic stress from one generation to the next. So we decided that if we could identify parents who are at greatest risk and bring their trauma histories out of the closet and agree to support them in a way that they feel not judged, that we might be able to create a new cycle of healthier parenting. We all know that raising toddlers is stressful sometimes, maybe all the time. particularly when you have certain issues, tantrums, colic, toilet training, hitting and biting, sleep problems. Those are examples of when parents are usually stretched a little thinner than usual, right? Now, if a parent has experienced toxic stress in their background, again, is their response going to be fight, flight, freeze, or can it be something else? And how do we better prepare at-risk parents for these inevitable moments? And furthermore, if parents have experienced trauma, we really didn't think that they would necessarily have appropriate skills or ideas for how to take care of themselves, how to identify when they needed help, how to model appropriate conflict resolution, how to do discipline that's developmentally appropriate, or in some cases, even playing with their child if they had not been played with as children themselves. And so our logic model is if we take all of our parents, figure out which ones had experienced toxic stress or adverse childhood experiences, and for those that haven't, we just go on with our standard anticipatory guidance. And for those who have, we do what we refer to as an enhanced anticipatory guidance. And so we started with 8 of our 28 providers piloting the screening. And Terry and I worked in the same half of the clinic in our site, and so it was pretty much just everybody who stood around us who started with the piloting. And we decided that we would start at the 4-month visit, give parents a questionnaire that contained the ACE screener along with a questionnaire about resilience and a list of potential resources that basically said, are you interested in any of these particular things? We also included a cover letter that explained the rationale for the screening tool and what we plan to do with the information. And we chose 4 months for 2 reasons. One is that by the 4-month visit, the parents have already had a couple of visits with us, and so the relationship is a little bit more established. We felt that asking them as new patients might be a little overly invasive. And the other is that, as we all know, 4-month-old babies, as Terry puts it, are the happiest critters on the planet. If you do anything halfway right, a 4-month-old is going to smile at you and laugh at you and coo, right? So you can take parents who are struggling and say, look at that. Your child just smiled at you. Keep going, right? So you can build off of that strength. The other thing we did in terms of protecting privacy is that we created a confidential field within our electronic medical record that doesn't print into notes so that I can track it and see it every visit, but it doesn't print into notes if the patient leaves our practice for whatever reason, so that we thought would minimize risk to families. And parents are aware that we're documenting it, but it's in a way that won't be seen. And then for our meaningful conversations and follow-up, I relied very heavily on connected kids. There's some great anticipatory guidance subjects that you can bring up that are listed out in connected kids. So these are some examples. So at the 4-month visit, if we see a family that where the parents have high ACEs, we talk about how the parents are getting along, how are they agreeing on parenting issues, some of the conflict resolution, but also a lot of the self-care stuff, because I do believe that parents need some permission for self-care when they have a small infant. They have this tendency to invest everything in the child and forget to eat or sleep or exercise or do other things that are going to be helpful for them. And then, as you can see, there's some other exercises and some other handouts that we provided for the different age groups. I really like the social connections exercise out of Connected Kids at the 6-month visit, which, when things are not stressful, the parents are thinking about who's my network, who are the people who care about me and my kids, so that if something goes wrong, I have a list of who I can talk to. We added these decision support questions to the anticipatory guidance sections of our visit templates. So again, we decided that decision support would be important for helping remind people what we're asking about. We again use some of the Connected Kids resources in the exam rooms. So some of the brochures are things like children learn a lot when they play. So again, getting at the developmental promotion. We use some of the 0 to 3 resources as well. Our care coordinator tracked down some of the community resources, and then most of our conversations, again, have been focused on parental resilience and how to really get parents taking care of themselves and having a good approach to parenting. Now, all this to say, again, I'm a rank and file pediatrician, so we did this on a shoestring. So anybody in this room can do the same thing that we did, right? And none of these resources are out of reach. So, I'm going to stop there, but I will just add one comment, and this is my spin on Dr. Burke-Harris's comment earlier. If you're waiting for the perfect evidence-based approach to this, don't, right? This is a field that is ripe for innovation. So your best idea that's rattling around in your head right now, take it home and do it, right? Sorry for the Nikeism. If I look out the west window of my office, I can almost see the Nike World Headquarters, so I have a lot of Nikeisms, and Just Do It kind of comes into my office a lot. We're all brainwashed out there. But I would say the other Nikeism that I like, and this came from a couple years ago when my beloved football team, the Oregon Ducks, lost the national championship for the first time. Nike came out with an ad that said, "Everyone loses games, few change them." Right? So even if your best idea rattling around in your head doesn't become the standard of care, you've still changed the game. So this is not a quote about football. This is a quote about continuous quality improvement. So try it. If it doesn't work, figure out something else. But you've changed the game by trying. And there's some resources. And if anybody has any, if you are taking your best idea and want to shoot it past me or get some moral support, my email's there. So feel free to shoot me a letter if you need some help.